بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we will handle the second part of the topic uh, dealing with imaging of the soft tissue tumors. And if you remember from the first part of this talk, we handled the imaging modalities, the ways of examination, the important findings or the important values of each imaging modality. Then we classified the soft tissue tumors into 12 categories, and we started by the first category, which are the tumors of the connective tissues. We have finished with this part in the first section of these talks. Now, in the second part, we will deal with the fibrohistiocytic tumors, the tumors of fat, and the tumors of the blood vessels, and as well as the tumors of the lymphatics. And starting by fibrohistiocytic tumors, we have five main lesions, which are the giant cell tumor of the tendon sheath, pigmented velonodular synovitis, the xanthoma, benign fibrous histiocytoma, and the malignant fibrous histiocytoma. Starting by the giant cell tumor of the tendon sheath, and this is also known as tenosynovial giant cell tumors, which include the two topics, the giant cell tumor of the tendon sheath as well as the pigmented velonodular synovitis. Then both categories belong to the same entity and almost have the same imaging criteria. But giant cell tumor of the tendon sheath usually occur peripherally around the tendons, and the pigmented velonodular synovitis is usually located in the major joints, particularly the knee. And the giant cell tumor of the tendon sheath is typically presenting in the third to the fifth decades of life with a slight female predilection, and is considered the second most common soft tissue mass in the hand and wrist. It mainly affects the flexor tendon sheath of the first three fingers, and in the X-ray you can see a soft tissue lesion which may be associated with erosion of the underlying bone, as you can see in this example, or may not associated by bone erosion. Bony changes are seen in about 20% of patients. Then the issue of periosteal reaction, tumor calcification, or the presence of cystic changes are not well known in this particular type of the tumor. Ultrasound will show a homogeneously hypoechoic lesion with a free movement of the tendon within the lesion. An MRI will show the similar findings to pigmented velonodular synovitis, which include in T1 intermediate signal, T2 dark signal, and some increase in the signal in the stir images, as I will mention. And you should remember that both the giant cell tumor of the tendon sheath as well as the pigmented velonodular synovitis will show variable degree of enhancement. Then locally aggressive and malignant tenosynovial giant cell tumor can be seen, and the metastases usually occur to the lymph nodes and the lung. And this is an example of a patient presented with left ring finger nodule for 6 weeks. There is no history of trauma, no pain, and tingling or skin discoloration. You see a homogeneously hypoechoic lesion, which is which is on the dynamic scan, as I mentioned here. It shows free movement of the lesion as regard to, or free movement of the tendon regarding the lesion. And this is one of the best benefits of ultrasound. It is the dynamic imaging, and you can image the lesion while or during motion. And this is one of the values of ultrasound, of course, compared to CT and MRI. Then the lesion is solid and homogeneously hypoechoic, may show posterior acoustic enhancement, and there is no calcification, cystic changes, and the lesion is not compressible, as you know that this is a solid, not a cystic lesion. And this is an example of a giant cell tumor of the tendon sheath in the sagittal stair, sagittal T1 weighted image, axial T1 and axial stair, and you can see the tumor is almost totally encasing the tendon, and there is some impression or benign scallowing of the adjacent cortical bone of the related phalanges. In another example of a giant cell tumor in the dorsum of the hand, you see the tumor is of intermediate signal in the T1 and very dark signal in the T2 weighted images. If you inject contrast material, it will enhance. Another example of a giant cell tumor of the tendon sheath, and you can see soft tissue lesion or soft tissue swelling associated with some cortical erosion and a little bone sclerosis related to the impression of the soft tissue lesion on the adjacent bone. Then if you can see this, and the age of the patient is uh, towards the young age, then the differentiation between giant cell tumor of the tendon sheath and synovial sarcoma may be somewhat difficult. But if you remember that giant cell tumor usually show dark signal on the T2 weighted image because of the hemosiderin, but synovial sarcoma will show bright signal or mixed signal on the T2 weighted images. There is no hemosiderin in this tumor. And this is another example, and you see the soft tissue mass and some impression on the cortex of the bone. The mass is a little bit hypervascular, as you can see in the Doppler study. Ultrasound and the Doppler of a giant cell tumor of the tendon sheath. This is T2 weighted image, and this is T1 post contrast after fat suppression. You see the nodule in the finger. It shows some vascularity on Doppler examination. It is predominantly hypoechoic, and whenever you inject contrast material, there is significant contrast enhancement. And this is another example. You can call this pigmented villonodular synovitis. It is located in the um, tarsal tunnel of the ankle joint, and you can see a mass of low signal in the T1 and some increased signal in the stir images, and there is appreciable post contrast enhancement. Another example, and you see here there is a mass in the tarsal tunnel with low signal in the T1 and mixed contrast enhancement in the T1 fat set after injection of contrast. Then you may have to read this entity, this statement. When the entire synovium of the joint is affected and there is a major villus component, the condition is referred to as diffuse pigmented villonodular synovitis. And when a discrete intra-articular mass is present, the condition is called pigmented villonodular synovitis or pigmented giant cell tumor of the joint. Then what I would like to say is that pigmented villonodular synovitis and the giant cell tumor of the tendon sheath belong to the same category. They show the same signal characteristics and enhancement, but the giant cell tumor of the tendon is somewhat localized, peripherally located, while the pigmented villonodular synovitis is more diffuse and is seen within the major joints. The differential diagnosis of these category of lesions include the ganglion cyst, which will show bright signal in the T2 weighted image, pigmented villonodular synovitis, both belong to the same entity. Desmoid tumor, it has a characteristic location and characteristic appearance. Fibroma of the tendon sheath do not contain hemosiderin. And this is the pigmented villonodular synovitis, which has been mentioned many times through the course of the musculoskeletal imaging. It is a rare proliferative condition of the synovium. Some consider it as an inflammatory lesion, others consider it as a tumor, and it affects the synovial membrane of the joints, the bursa, and the tendon. And as I have mentioned, it has in the view of many neoplastic background with vellus projections in the joint containing hemosiderin deposition. As this is a monoarticular disease, and in around 80% of the cases, it affects the knee joint. Other it occurs predominantly in the second to the fifth decades of life, and it presents by joint swelling, pain, and sometimes dysfunction of the affected joint. In the early days before the era of CT and MRI, we diagnosed pigmented villonodular synovitis from the plain films by these manifestations, which include joint swelling due to effusion, extrinsic marginal pressure erosions, as you can see here, erosions or osteolytic lesions on either side of the articular line, indicating that this is an articular disease or a joint disease, not a bone disease. If you see lesions on either side of the articular surface, then you know that this is an articular disease, not a bone disease. The lesion do not contain calcium, and this is very important in the differential diagnosis. There may be dense soft tissue masses because of the hemosiderin around the joint, and hypertrophy of the synovium is of course seen by CT or by MRI, and bone erosions, if they are small, they are better seen by CT scan. But the MRI appearance is quite pathognomonic. You can see multiple masses inside the joint, and these masses have a signal characteristics, including the intermediate signal in the T1 and the dark signal in the T2 weighted images. On stereo images, they may show an increased signal. On gradient image, they may demonstrate blooming due to the presence of hemosiderin. And because of this hemosiderin, the differential diagnosis will include other conditions which are associated with iron deposition in the joint, like hemophilia, for example, and conditions which produce calcification near or in the joint, like the pseudogout, for example, and the tophi of gout. But you remember that the gouty lesions do not enhance with contrast material, and also, but the pigmented villonodular synovitis will show significant enhancement, as I mentioned. Then this is one of the most classic situations or locations of pigmented villonodular synovitis in the knee joint. It's located in the anterior aspect of the knee, in the Hof's bed of fat. The lesion will show intermediate signal in the T1 and some increase in the signal in the STIR image. After injection of contrast, and you can see significant contrast enhancement. And of course, if you have a PET CT, it will show an increased tracer uptake. Another example of pigmented venular synovitis in the ankle joint: low signal, intermediate signal in the T1, dark signal in the T2, some increase in the signal in the stir images, and almost homogeneous contrast enhancement. This is another example of a pigmented venular synovitis in the anterior aspect of the ankle. You see the intermediate signal in the T1, dark signal in the T2, and bright signal in the stir images, and the contrast enhancement. Of course, this lesion may be mistaken for synovial sarcoma, but you should remember that synovial sarcoma will show bright signal in the T2 weighted image, or at least mixed signal due to the presence of fluids and some other soft tissues. And of course, the synovial sarcoma do not contain hemosiderin. And in most of the cases, and you will have the biopsy, as I have mentioned in the first part of these lectures. Then we came to another lesion, which is the xanthoma. And xanthoma is considered the localized reactive proliferation of lipid-laden histiocytes, and it affects patients with abnormal serum lipid profile, those with familial hypercholesterolemia, for example. They may complain of this particular disease, and if the manifestations are seen clinically, they should have to check the triglyceride level in the blood. Then most of the lesions present as nodular or fusiform, slowly growing painless masses related to or arising in the tendons. And particularly, the Achilles tendon is one of the most common tendons in the body to be affected by this disease. And as I mentioned here, involvement of the Achilles tendon, which may be bilateral in about 90% of cases, is the hallmark of this disease. And detection of familial hypercholesterolemia is very important because of the high risk of cerebral and cardiac ischemic attacks. The Achilles tendon will be markedly enlarged with a hypoechogenic picture on ultrasound, and because of these lipids and mixed with the tendon fibers, and you got a big mass of predominantly low signal in all part sequences, as I will show to you. Then if you control the hyperlipidemia in the blood, the literature says that there may be regression of the disease. This is an example of the xanthoma of the Achilles tendon. You see the huge enlargement of the Achilles tendon in the T1 weighted image and in the T2 or stir image, and also after contrast enhancement. These lesions do not usually show significant enhancement. And this is another example by plain X-ray. You see the shadow of the Achilles tendon is very big. The T1 and the T2 or stir images, and you see the Achilles tendon is severely enlarged. And this should not be diagnosed as tendinosis or tendon degeneration, because this is a huge lesion, not just a fusiform enlargement of the tendon. Then we came to the benign fibrous histiocytoma, and this is a tumor which arises usually in the skin or sometimes in the deeper soft tissues. Is considered by the literature as one of the most common benign soft tissue tumors of the skin, and it is seen in young adults. It's usually painless, slowly growing, may be flat or pedunculated. The skin may be red or black, as you can see here, and multiple lesions are seen in about 30% of the cases. Deep-seated lesions are large and may reach a big size and affect middle-aged patients. Then the benign fibrous histiocytoma is a solid hyperechoic mass on ultrasound. It appears a hypo-to-isodense mass on CT images, and on MRI, the lesion has no specific MRI criteria. It's just an intermediate signal in the T1 and T2. Then, as I have mentioned before, if you cannot reach the accurate diagnosis of a benign lesion by ultrasound, you should go for MRI and you should follow this MRI by biopsy. This is a benign fibrous histiocytoma, which is involving the iliac bone with intra and extra pelvic components. Another example of a benign fibrous histiocytoma in the popliteal fossa, CT without contrast, CT with contrast, MRI T1, MRI T2, and MRI T1 post contrast with fat suppression. And you see the tumor is enhancing both in the CT and MRI with non-specific MRI criteria, low signal in the T1 and the high signal in the T2 weighted images. Now you remember that we have mentioned in the first part of these talks that the adult type of fibrosarcoma as well as the malignant fibrous histiocytoma are now considered as pleomorphic undifferentiated sarcomas. But of course, this name is still used in the literature as well as this name as well. But you remember that adult fibrosarcoma and malignant fibrous histiocytoma are both included under this title. And why we mention adult fibrosarcoma in this particular domain? Because of this. And we are dealing with the benign fibrous histiocytoma, and the malignant form of this tumor is the malignant fibrous histiocytoma, which is considered analogous to adult fibrosarcoma, and both are included under this title, which is pleomorphic undifferentiated sarcoma. Then, as I have mentioned before, that most of these sarcomas have a non-specific MRI appearance, and it is predominantly of low signal in the T1, high signal in the T2, and they will show some contrast enhancement. Then we came to the next group of tumors, which are the group of tumors arising from fat. And these are 8 types, and we including lipoma, the fibrolipoma, lipoblastoma, intramuscular and intermuscular lipoma, lipoma of the tendon sheath, parosteal lipoma, diffuse lipomatosis, hyperinoma, and the malignant component, which is the liposarcoma. Starting by lipoma, which is the most common soft tissue tumor seen in about 2% of the population. It is usually seen in the 5th to the 7th decade of life. And lipoma is a very easy diagnosis, both clinically and by imaging. This is a slowly growing lesion, which is usually painless, and the lipoma is a well circumscribed soft tissue mass, usually encapsulated, composed entirely of fat. Sometimes the big lesions contain a small amount of non-fat component, and this will represent fibrous septations, areas of fat necrosis, blood vessels, and muscle fibers. Then lipomas are usually located superficially. If they are seen deep in the tissues, then there should be evaluated carefully because of the high possibility of being malignant. And the superficially located lesions are usually benign. Deeply located lesions may be benign or malignant, and they should be investigated thoroughly. Retroperitoneal lipoma is considered malignant until proved otherwise. There are 2 most common sites in the human body for liposarcoma, and these are the thigh and the retroperitoneum. So if you see a fatty mass in the thigh or in the retroperitoneum, then consider the possibility of liposarcoma and investigate this thoroughly to reach the final diagnosis. Then, in 5 to 15% of the patients, lipomas are multiple, and you may see more than one. And I mentioned before that in the X-ray, you can see lipoma as a radio translucency mass related in the subcutaneous tissue, and the incidence of calcification is about 11% in these particular types of tumor. Then you should know that calcium is commonly seen also in liposarcoma, and this is not considered a feature of a benign lesion. Then we all know that lipomas should be echogenic on ultrasound, but according to the literature, lipomas may be hyperechoic in about 40% of the cases, isoechoic to the adjacent tissues in another 40% of the cases, and maybe hypoechoic in 20% of the cases. There is no acoustic shadowing, and there is no blood supply or Doppler flow within the lesion. And if you see a heterogeneous texture, mixed echogenicity and hypoechogenicity with Doppler flow and large size, then be careful about the possibility of liposarcoma. Lipoma is a hypodense mass. Its density is almost similar to the subcutaneous fat, and whenever you measure the attenuation value of the lesion, it ranges from minus 65 to minus 120 Hounsfield unit. And there is no internal soft tissue component, maybe minimal soft tissue shadows like the fibrous septa and the blood vessels are acceptable. Calcification are more frequently associated with liposarcoma, and whenever you see calcium, it should be arise the attention for this lesion to exclude the possibility of being malignant. The lesions cannot be confidently differentiated from liposarcoma by imaging. And you know that well-differentiated liposarcoma looks exactly like lipoma. And this, then, if you see a fat-containing lesion in the thigh or in the retroperitoneum, uh, even if it is totally formed of fat, you should exclude the possibility of liposarcoma, of course, by biopsy. And intramuscular lipomas may have a striated appearance and may simulate liposarcoma. You remember the fibroelastoma dorsi? It has a striated appearance, but its location and the characteristic appearance help in the diagnosis. This is a big lipoma in the thigh with some fine linear streaks inside, and this is acceptable in a simple lipoma, but being in the thigh, you should assess for liposarcoma. Then in MRI, lipomas have a characteristic high signal in the T1 and also in the T2 weighted images with suppression of the signal in the fat suppressed sequences. And then this sequence, you can see the septations within the lipoma more better in the fat suppressed images. And when there is no suspicious features like the presence of calcium, the presence of a significant soft tissue component, MRI is 100% specific for the diagnosis of lipoma. This is an ultrasound of a lipoma in the thigh, and you see in the T1 weighted image some strands within the tumor with suppression of the signal in the fat suppressed images, and you see the subcutaneous fat is also suppressed, and you can better visualize the internal septations. Another case of lipoma in the back of the knee, and you see a high signal in the T1 and suppression of the signal in the fat suppressed image. lipoma near the elbow. In the T1 weighted image, it shows similar signal intensity to the subcutaneous fat, while in the fat suppressed image, it shows suppressed signal compared to the fat as well. Then the second type of these of the tumors in this category is the fibrolipoma or the fibrolipomatous hamartoma, and this is a particularly lesion which affects the nerves, and the most common nerve affected by this lesion is the median nerve, which is involved in about 80% of these lesions, but the lesion can also involve the ulnar nerve or the radial nerve or the dorsum of the hand. And sometimes there is macrodactyly in patients who are affected by fibrolipoma of the median nerve. Then the fibrolipoma has a very, very characteristic appearance. The nerve is markedly enlarged, and it shows the appearance of cable-like structure in the axial image, with the black dots representing the nerve fibers, and the hyper-intense signal background represents the fat. And in the coronal or sagittal images, it has an appearance which is usually referred to as a spaghetti-like appearance because of the nerve fibers are black and the major component of the lesion is bright. Then we came to the third lesion in this category, which is lipoblastoma. And this lipoblastoma is a tumor of the pediatric age group. 88% occur below the age of 33 years, and 55% of the cases are seen below the age of 1 year. And this lipoblastoma is a tumor big in size, containing fat and maybe other soft tissues. Then lipoblastoma is usually painless. Then this is considered one of the rules in imaging. If you see a fat containing mass in a child below the age of 3 years, consider lipoblastoma, even if it contains some soft tissues within the fat, because liposarcoma is extremely rare in infants and children. Then you see here a fat-containing lesion in the T1 and also in the CT scan in a child 50, it's not a child, adolescent, 15 years old, and this was a lipoblastoma. A male patient, male child, 5 years, with a fat-containing lesion with some soft tissues inside, and this is lipoblastoma. And this is a 1 year old male with a fatty lesion in the back. And this lesion was proved to be a lipoblastoma. It's stated here that liposarcoma are extraordinarily rare in patients less than 10 years of age. Therefore, a lesion containing fat in a young child is almost invariably a lipoblastoma. Then we came to the fourth type, which is intramuscular lipoma, and it's just a mass containing fat located within one of the muscles. And one of the important criteria of this lesion is its infiltrative nature, which indicates a benign lesion. The lesion has an infiltrative character within the muscle. It does not have a smooth outline, but it has some extensions within the muscle, and this is diagnostic of being a benign lesion. Another lesion within the iliopsoas muscle, and you see the fat, its fat content by CT. Then we have mentioned something about the lipoma arborescens, which is a fatty lesion occurring within the joints, and the etiology is unknown. It may be associated with osteoarthritis, diabetes, chronic synovitis, some rheumatoid arthritis, and so on. The lipoma arborescens is made of a tree like fronts made of fat within the joint with the presence of synovial effusion. Bilateral presentation is well known, and even multiple joint involvement can be seen. CT and MRI will show the fatty synovial mass with joint effusion, and the treatment is by synovectomy. This is a good example of lipoma presence, sagittal T1, coronal T1, coronal stair, and axial T2. You see the front-like fatty mass with branches inside the joint with a significant amount of joint effusion. Lipoma presence may be differentiated from pigmented villonodular synovitis. This lipoma does not enhance synovial osteochondromatosis. Osteochondromatosis will not show the signal of fat in all bulk sequences. Plexiform neuroma, it will enhance with contrast material, and synovial hemangiomatosis will not show the signal of fat in the T1 weighted image. The tendon sheath lipoma is just a lipoma surrounding a tendon sheath, like the giant cell tumor of the tendon sheath, but this is made of fat. And you can see fat signal in the T1 weighted image, and there is suppression of the fat signal in the T2 weighted image around the tendon sheath. And this is tendon sheath lipoma of the tibialis anterior tendon. You see the tendon surrounded by a fatty mass, and in the stair images, they said that the mass disappears because it will be exactly of similar signal intensity to the subcutaneous fat, and then you cannot see or cannot identify the tumor. And this is also here in the T1 weighted image. The fatty mass is surrounding the tibialis anterior, and in the T2 weighted images or then the stair images, you see it looks as if it disappeared. Then parosteal lipoma is the lipoma which is adjacent to the periosteum or to the cortex of the bone. And being adjacent to the cortex of the bone, it will initiate some reaction in the adjacent cortex, resulting in this appearance of this protrusion of or ossification at the contact line between the lipoma and the bone. And this is considered one of the diagnostic criteria that this is a benign lesion and is known as parosteal lipoma. Its incidence is about 0.3% of all lipomas, frequently seen in the arm, in the forearm, in the thigh, and in the calf. It is usually asymptomatic and may reach a large size, about 20 centimeter in diameter. X-ray will show a radiolucent lesion like this one and adjacent to the cortex of the bone with or without osseous changes. The osseous changes may be in the form of bone projections like this, cortical erosion, perosteal reaction, intra-lesion, metablastic bone formation. And you see here, this is an example, and you got a fatty mass which is adjacent to the cortex of the femur with this ossification extending into the lipoma. In the CT scan, you see the fatty mass, and in MRI fat suppressed image, you see the fatty mass with the bone projection. Another example of a parosteal lipoma in the thigh with the classic bony reaction or protrusion coming from the femoral cortex into the lipoma itself. Then another entity which is known as diffuse lipomatosis. And diffuse lipomatosis is an extremely rare condition, commonly affects large portions of the trunk and extremities. It is diffuse overgrowth of mature adipose fat, histologically similar to simple lipoma. Extensive fat either through the trunk or through the extremities or both. Then the fat will infiltrate muscles and leading to deformities and limb asymmetry, as you can see here. Then most of the cases occur during the first 2 years of life, but of course you can see it in adult patients. And this is another an example of diffuse lipomatosis. You see the neck is almost totally infiltrated by fat, the shoulder region at the back, and the thoracic cage also, or the chest wall, is involved by this fat. Then we came to the hypernoma, which is known as lipoma of the immature adipose tissue, or lipoma of embryonic fat, or fetal lipoma. You see that this lipoma will arise from the brown fat, or the fat of the fetus, and it will appear almost exactly similar to the lipoma, except in some differences. And these differences I will mention in a moment. These are well circumscribed, encapsulated tumors, and they may infiltrate the surroundings. Lipoma do not usually infiltrate the surroundings. The usual locations are in the scapular and interscapular region, and even in the mediastinum. Hypervascular mass. Then this hypernoma is a hypervascular mass, and you can see vessels on Doppler ultrasound. You can see vessels on CT and on MRI. The size of the lipoma is in the range of any other lipoma. Then number one, the hypernoma can infiltrate the surroundings. Number two, it is a hypervascular mass. You remember that simple lipoma is not hypervascular. The lesion is hyperechoic with internal vascular channels. Most of the 40% of lipomas will appear hyperechoic. And lipoma will show some septations and other soft tissues. It's accepted also in the simple lipoma, and may show poor or strong contrast enhancement, but lipoma do not show contrast enhancement. Then this is slightly hypointense to the subcutaneous fat on T1 weighted image. You know, the simple lipoma is almost of iso-intense signal to the subcutaneous fat. This fat is brown and is not as high signal as to the subcutaneous fat, and is frequently hyperintense to the normal muscle tissue in the T1 weighted image, and this is usual for both lipoma and hypernoma. The lesion is almost as intense as fat on T2 weighted image, and in the T2 weighted image, the lesion may be similar to the subcutaneous fat. And this is mentioned in the literature, but you may not see in the real practice, where the fat in the lesion is not suppressed on the fat suppressed images, but many times you can see that hypernoma will be suppressed on fat suppressed images. Then angiography will show intense vascular blush of the lesion, and there is no neovascularity, there is no hypervascularity of neoplastic tissue, for example, or arteriovenous shunting. And the differentiation from liposarcoma may be impossible. And many times, if you are going to have a biopsy from this lesion, be careful, because this lesion is hypervascular. And this is a hypernoma. You see the fatty lesion. It's relatively hypodense on the CT image, but not as hypodense as the subcutaneous fat. And you see the enhancing vessel related to the lesion. And in this example, in the T1 weighted image, the lesion is not bright as the subcutaneous fat. In the T2 weighted image, the lesion may be similar to the subcutaneous fat, but in fat suppression, and you see the lesion is a little bit suppressed. After contrast enhancement, lipoma do not enhance, but hypernoma will show enhancement. This is a hypervascular lesion. Then we came to the malignant component of this group of fatty lesions, which is the liposarcoma. Liposarcoma is considered the second commonest type of soft tissue sarcomas. Liposarcomas are found in adults between the age of 40 and 60 years. and they are rare in the children. 70% are seen in the extremities, commonly the thigh and the retroperitoneum. And I have mentioned that the most two common locations in the human body for liposarcoma are the thigh and the retroperitoneum. Then so many criteria are suggested by the literature for to favor the liposarcoma over a lipoma. Number one, inhomogeneous attenuation, and you see some fat and some other soft tissues, significant amount of soft tissue within the fatty mass, poor definition of the margin, invasion of the adjacent structures, and the presence of calcium. Then high-grade lesions are devoid of fat. High-grade liposarcoma may not contain any fatty lesion on imaging at all, and it is exactly similar to other types of sarcomas. And high-grade lesions, especially in the retroperitoneum, have a very poor prognosis. The recurrence rate is about 70%. And this is a big mass in the anterior aspect of the thigh, and this mass is, of course, do not show signal intensity similar to the fat. But liposarcoma, if it contains significant amount of fat, can be mistaken for simple lipoma, and if it contains a poor amount of fat, it may be mistaken for any other type of sarcomas like adult type fibrosarcoma or malignant fibrous histiocytoma or leiomyosarcoma, and lesions in the retroperitoneum of course cannot be mistaken for angiomyolipoma because angiomyolipoma has a significant amount of fat and is present in the kidney, and this is adrenal myelolipoma is almost totally containing fat. And this is the liposarcoma in the back of the thigh. There is a fatty mass with internal septations and a good amount of soft tissues within the lesion. And you should remember that simple lipoma do not contain vascularity. Simple lipoma is usually echogenic. And if you see a mixed echogenicity, hypo and hyper, and some some vascularity on Doppler imaging, then you should think of liposarcoma. And this is another example, T1, T2, and T1 post contrast. You see significant contrast enhancement on this T1 fat suppressed image. This is liposarcoma of DR. And this is retroperitoneal liposarcoma posterior to the kidney. The mass is almost totally made of fat with fine internal septations, then can be mistaken for simple lipoma. But remember, there is no simple lipoma in the retroperitoneum unless verified by histopathology. You should consider any fat-containing mass in the retroperitoneum as liposarcoma until proved otherwise. And this is another example. You see a fatty mass with a significant amount of soft tissues and internal septations adjacent to the kidney, and this was a retroperitoneal liposarcoma. Finally, we came to the vascular and lymphatic lesions, and we will start first by the arterial aspect, and then we go to the lymphatic aspect. In this domain, we have the benign vascular tumors, the angiomatous syndromes like the Maffucci syndrome, Klebel-Trenaunay syndrome, Osler-Weber-Rindeau disease syndrome. Then we have what's known as the glomus tumor, which is totally different from the chemodictomas, the lymphangioma, and the lymphangiomyomatosis. Starting by the hemangioma. Hemangioma is now included into a major category which is known as soft tissue venous malformations. And these soft tissue venous malformations include these 5 items. Number 1, the capillary hemangioma, which is present mainly in the pediatric age group. the cavernous hemangioma, which is commonly seen in adults, arteriovenous malformation, venous angioma, and the mixed type of these categories. Then we have five soft tissue venous malformations. The hemangioma is one of them. The hemangioma is of two types, the capillary seen in the pediatric age group, the cavernous seen in adult age group. Sorry. As I mentioned before, that one of the best diagnostic criteria is of the hemangioma is to see calcified philippoli in the soft tissues where the hemangioma is present. And this is an important, very important value of the plain X-ray. So if you remember in the first part of these lectures, I said that the plain X-ray, although it looks of little significance, but it sometimes will provide important information, very helpful for the diagnosis. Then you see calcified philippoli, then you know that you are dealing with a hemangioma. On the ultrasound, hemangioma may appear hypoechoic, and sometimes it will appear echogenic, and you can see some vascularity in the vicinity of the lesion. And the tier 1 weighted image, the lesion is on intermediate signal, and the T2, it has a very bright signal, and in the gradient image, blooming may be due to the calcification of philippoli. If you inject contrast material, the lesion will enhance significantly. And this is one of the appearances of hemangioma by ultrasound and Doppler. You can see the lesion and you can see some echogenic foci inside, but you cannot see any Doppler flow around the hemangioma or even little flow. X-ray of the elbow. Without this X-ray, this lesion cannot be reached from MRI because when you see a lesion which is a little bit bright in the T2 weighted image, and after injection of contrast, it shows some enhancement. But if you can see these philippoli, then the diagnosis is very easy. Hence, the importance of the plain X-ray. Then here in the T1 weighted image, the lesion is black. In the stir image, the lesion is bright. After injection of contrast, the lesion showed enhancement and it was biopsied and proved to be a hemangioma. In the T1 intermediate signal, high signal in the T2 weighted image and significant post-contrast enhancement. And this is another lesion in the gluteal region, low signal in the T1, high signal in the T2, and some contrast enhancement in this T1 uh, with fat suppression. Hemangioma can also occur inside the joint, and hence the importance of the plain X-ray. Once more, you see the philippoli within the knee joint, and then you see a lesion which is bright in the T2 and bright in the SIR images with some enhancement, diagnostic of hemangioma. And inside the brightness of hemangioma, and you can see linear black shadows which represent fibrous septation or patent vessels or both. Then one of these angiomatous syndromes is the Maffucci syndrome, which is congenital non-hereditary mesodermal dysplasia and is characterized by, as you know, two main lesions, the enchondromas, multiple enchondromas similar to Ollier disease, and soft tissue venous malformations, which are hemangiomas in the soft tissues that are identified by the presence of calcified philippoli. Then the skeletal and vascular lesions are unilateral in about 50% of the cases. The vascular lesions are identified by the detection of philippoli. Enchondromas are multiple expanding lesions in the bones with matrix calcification, as you all know. Enchondromas in Maffucci syndrome and Ollier disease may be complicated by chondrosarcoma in about 30% of the cases. then this disease may also participate for the increased incidence of other malignancies like pancreatic carcinoma and glioma. This is a typical example of Maffucci syndrome in a male adolescent, 18 years old, with calcified philipoli indicating hemangiomas, expanding lesions indicating enchondromas. Another example in a male 20 years old with expanding lesions representing enchondromas, calcification in the soft tissues representing philipoli denoting hemangiomas. Then Klippel-Trenaunay-Weber syndrome is one of these vascular syndromes. It is the incidence, as you can see here, and it usually presents in infancy and is unilateral in most of the cases, may affect the upper limb, of course, and may affect the lower limb. The lower limb is affected in about 95% of the cases. And there is a significant enlargement of the affected limb, and there may be skin pigmentations, as you can see here. And if you have imaging, and you will see some vascular abnormalities, as I will show to you. Then one of the complications, which is very serious, is the rectal or bladder hemorrhage, which is secondary to the presence of vascular malformations in the pelvis. These vascular malformations, of course, are present in the limb and can be seen in the GI and genitourinary system as well. The treatment is usually conservative by stocking and pneumatic compression. Sometimes you may perform sclerosis of the superficial varicosities, and you may resort finally to the surgical treatment. Then Klippel-Trenaunay is a triad: port wine nevi, skin pigmentation, bony and soft tissue hypertrophy of an extremity, and varicose veins, venous malformations of unusual distribution. Then if you have imaging, and you can see that the limb is considerably enlarged compared to the opposite one, and there are too many vessels which represent venous and lymphatic malformations. And this vein, which is usually seen by MRA or CTA, is known as the marginal vein or cervile, is pathognomonic. This is a subcutaneous vein in the lateral aspect of the calf, as you can see here. But if you look to the patient, it's usually the diagnosis is easy whenever you see that the limb is significantly enlarged and you got skin pigmentation. If you have imaging, you may see hypertrophy of the bone leading to pelvic deformity like this you can see here, and subcutaneous and intermuscular vascular abnormalities, as you can see in this MRI. Then the malignant component of these vascular lesions is the angiosarcoma, and sometimes was known as hemangiopericytoma, but I have mentioned that hemangiopericytoma is now coupled with the solitary fibrous tumor, and they both consider as benign lesions. And also the hemangioendothelioma, but angiosarcoma is one of the sarcomas that arise from the vascular structures, and it has no specific imaging criteria. They are considered one of the aggressive lesions in the domain of sarcomas, and frequently have metastases at the time of the diagnosis with a very high recurrence rate. Then the lesion can occur in the skin and in the soft tissues, seen in males more frequent than in females. And this syndrome, Stewart-Travis syndrome, is diagnosed if you see angiosarcoma after mastectomy, lymphedema, and in the upper limb. Then the mass has non-specific appearances on MRI with significant post-contrast enhancement. And you see here there is a mass of in dark signal or intermediate signal or iso-intense signal to the muscles, and the T2 weighted images show mixed hyper intensities. And after contrast injection, you see areas of breakdown inside the lesion. Then this appearance can fit for any of the sarcomas you know, and you should have the diagnosis by biopsy. Then we came to the glomus tumor, which is known as glomangioma. And this glomangioma is one of the lesions present particularly in the upper limb, especially under the fingernail. And this is a hamartoma rather than a true tumor. And the incidence rate is about 1 to 5% of the soft tissue tumors in the hand. Then this tumor should not be confused with the paraganglioma, like the glomus jugular, glomus vagal, and the carotid body tumors, and so on. These are paragangliomas, but the glomus tumor we mean by this subangular vascular lesion. It is recognized in females more common than males, especially in the fourth and the fifth decades of life. Multiplicity is seen in about 10% of the cases, and 75% of the lesions are seen in the hand. This lesion is small and very painful, firm red blue nodule under the fingernail. Then, if you have the plain X-ray, you may see some osteolysis or bone rarefaction in the terminal phalanx of the affected finger. Ultrasound will show hypoechoic hypervascular nodule in the region of tenderness. It appears in MRI as low signal in the T1, high signal in the T2, and shows uniform post-contrast enhancement due to hypervascularity. And this is you can call it glomus tumor and you can call it glomangioma, and the tumor is underneath the fingernail. Low signal in the T1, high signal in the T2, and some enhancement after injection of contrast, and you can see its impression on the underlying bone, denoting its benign nature. And finally, we came to the lymphatic lesions, which include two lesions, the lymphangioma and the lymphangioliomatosis. Lymphangioma is a benign lesion of vascular origin, of lymphatic origin, and it is the lymphatic equivalent of the hemangioma, most commonly seen in the pediatric age group before the age of 2 years. Then this lesion is commonly seen in the head and the neck, sometimes extend to the axilla, and many times it go to the mediastinum. This lymphangioma is also known as cystic hygroma, and an ultrasound it appear multilocular with hypoechogenicity and maybe acoustic enhancement due to cystic changes. Sometimes you got hyperechoic internal echoes due to debris, infection, or hemorrhage. And on the Doppler study, you may see some vascularity. MRI will show fluid signal and is low signal in the T1 and high signal in the T2. But one of the best diagnostic criteria is the presence of fluid levels on MRI due to sometimes the presence of proteinaceous contents or hemorrhage. Ultrasound, CT, and MRI are diagnostic of lymphangioma by the presence of multilocular cystic lesion with some debris inside and minimal enhancement of the septations. And this is lymphangioma in the neck, which is a common location. You see low signal in the T1, high signal in the T2, and the enhancement of the septation. There is some hyper intense signal in the T1 due to hemorrhage or proteinaceous content. The fluid level is one of the best diagnostic criteria of lymphangioma on MRI. And this is a 9 weeks old female presented by large cystic lesion in the neck, showing low signal in the T1, high signal in the T2, characteristic of cystic hygroma. Another lymphangioma in the neck by CT, fluid signal, MRI, low signal in the T1, high signal in the T2. Another case on the left side, hypoechoic lesion by ultrasound, low signal in the T1 and high signal in the T2, diagnostic of lymphangioma. Then we came to the lymphangiomatosis. Lymphangiomatosis is an extremely uncommon benign congenital disorder of the lymphatic system. Its cause is unknown, and the lymphatics in this syndrome increase in number and size, leading to hypertrophy of the limbs, as you can see here. And this will result in dilated sacs or cysts known as lymphangiomas or lymphangiomatosis. The lesion can invade the surrounding organs, causing morbid conditions. And the disorder has no sex predilection. And if you see here, this hand and fingers are significantly enlarged compared to the opposite one. In an infant, if this lesion may present in infants and adults, but it's more aggressive in children with poor prognosis. The death is usually a complication of accumulation of chyle in the pleural or precardial space. Lymphangiomatosis can occur anywhere in the body except in the CNS because it is devoid of lymphatics. Then you may need the cooperation of physical examination, chest X-ray, pulmonary function, ultrasound, CT, MRI, lymphoscintigraphy, and sometimes you may need to have a biopsy to reach the diagnosis. And you should remember that lymphangiomatosis affects the subcutaneous tissues. It does not involve the muscles and does not involve the bone. The resultant appearance will be in the form of significant increase in the size of the affected limb with extensive subcutaneous abnormalities, as you can see here. And this is lymphangiomatosis in a female 27 months old. And you see the extensive changes in the subcutaneous tissues, but the muscles are intact and also the bone is intact. Then Glove syndrome is an abbreviation for congenital lipomatous overgrowth, vascular malformation, and epidermal nevi. And recently they add S to the glove and S refers to the presence of scoliosis or skeletal and spinal abnormalities. This syndrome is nothing but considerable hypertrophy of a limb secondary to lipomatous hypertrophy. And it is not due to vessels, not due to lymphatics, it is due to fat. Then you can see that the limb is huge compared, of course, to the opposite one. And you may see some vascular malformations, but not as much as Klippel Trenauni or lymphangiomatosis. Then, in addition to nevi, skin may show some other marks or vesicles. You may also appreciate some pigmentations, but not similar to the Klippel-Trenauni syndrome. The skeletal deformities are in the form of scoliosis and maybe large, wide hand and feet, as you can see here. This is what we call Glove syndrome. There is unilateral hemihypertrophy of the body as well as the right lower limb because of fat and not because of the vessels or the muscles. Finally, you should know that The giant cell tumor of the tendon sheath and pigmented villonodular synovitis both belong to the same category, and they are characterized by typical location either in relation to the tendon or the joint, low signal in all pulse sequences in the T1 and T2, may show some brightness in the stir, blooming on gradient echoes, and strong enhancement after injection of contrast. Xanthomas are highly associated with familial or secondary hyperlipidemia and very commonly affects the Achilles tendon and is usually bilateral. Imaging features of either benign and malignant fibrohistiocytic tumors are nonspecific, like benign fibrohistiocytoma and the malignant fibrous histiocytoma. The majority of vascular tumors are benign, locating in the skin and subcutaneous tissue. Hemangioma can involve a large segment of the body if it is a part of a syndrome like Klippel-Trenaunay syndrome. And plain radiography is very essential for the diagnosis of hemangioma, very helpful because of its ability to detect phlebolli. MRI can be used to differentiate slow and high flow vascular malformations, and this also can be differentiated by Doppler ultrasound. The diagnosis of lipoma is very simple on MRI imaging if it has the classic features. Fat suppression technique is also very helpful in differentiating lipoma from other fat-containing tumors. Lipomas containing other mesenchymal tissues can simulate liposarcoma on MRI. Benign intramuscular lipoma should have infiltrating marsh or uh, uh, may show infiltrating marsh. Fatty mass below the age of 3 years is suggestive of lipoblastoma or lipoblastomatosis. The parameters for differentiation between benign lipoma and liposarcoma include location in the superficial or deep. Superficial lesions are usually benign. Deep lesions should be investigated to exclude the possibility of malignancy. A small size is in favor of a benign lesion. Large size is suggestive of malignancy. Internal composition of other soft tissues rather than fat is suggestive of liposarcoma. Contrast enhancement is also in favor of malignancy. Tumors of the lymphatic origin are rare and they are detected in the childhood. Lymphangioma can occur anywhere in the body except the CNS. Increased lesion detection is attributed to the high prevalence of perinatal ultrasound and fetal MRI. The absence of flow voids and enhancement are in favor of lymphangioma. Thank you very much. Alhamdulillah Rabbil Alamin.